the advanced approach of rehabilitation, assessment, and treatment, what you're going to learn in this particular 1.5 hours webinar. Okay, so try to be attentive, be focused, and try to implement that into your practice. Okay, so without wasting much time, I'll just start with my slide number 1. Okay, so the content for today's webinar, we are going to look in the overview of the lumbosacral joint. We are going to go through the Maitland assessment and a treatment protocol. We are going to target our main focus on the facet joint biomechanics. Because if you go through your physical therapy curriculum, or if I want to compare Maggie, they only focus on the generalized lower back. In this particular webinar, we are going to go into detail about single segments of the lumbar as well as the sacrum. We are also going to talk about the dysfunction syndrome. Then we are going to talk about McKenzie. In McKenzie, we are going to talk about the 2 syndromes which McKenzie classifies, the dysfunction and the derangement. We are going to teach you how to assess and diagnose based on the law of posteriority, and rehabilitation, the new tools which are available for the physical therapist to deal with any lumbosacral dysfunction. Okay, so diagnosis of the lumbosacral dysfunction seems complicated, but if your basics are strong, this diagnosis can be made very much simple. What I want you to understand from each and every slides which I have made has typical clinical reasoning behind it. Based on the classification of the sports injuries, the injury has been divided into 3 stages: acute, subacute, and chronic. Whenever any injury which happens either because of the internal trauma or an external trauma goes through ideally these 3 stages. There is one new sports medicine stage which has added, is called as a super acute stage, where the injury is less than 24 hours, like super acute. In that super acute stage, remember this, your most of the physiotherapy practice or techniques are contraindicated. The reason why, because whenever you have any kind of trauma, either internally or externally, you get something which is formed called as hematoma. This hematoma has a high chances that if you give any kind of movement therapy or electrotherapy or exercise therapy where there is enough amount of blood circulation going across that inflamed tissues, you have a high chances of getting a blood clot. So any kind of injury less than 24 hours, try to be more conservative. Don't give any kind of physical therapy approaches. Okay. In joint, basically someone comes to you with an acute slip disc less than 24 hours. Try to protect the lumbar joint as much as you can by giving just a compression. Don't try to move their joint because it's highly vulnerable to get it more injured. Okay, so this is just less than 24 hours. The symptoms of the slip disc may come after 24 hours. Okay, so remember that. So the golden rule is whenever the injury is in the very super acute stage, most of the physical therapy practices are contraindicated. Let them be cured with the help of medication or just the initial remedy like a compression or ice or heat, whichever part the patient is comfortable. Your main physical therapy would start from these stages after 36 to 72 hours when the acute inflammation has subsided. Okay, so these are basically the classification: acute, subacute, and chronic. Whenever you see any patients with the lumbosacral dysfunction, these 7 points, these physiological tissues, are the most important stuff. Your skin, your fascia, your muscles, your ligaments, your joint, your disc, and nerve. Whenever you assess any patient coming to you with the lower back pain, try to evaluate through all this physiological system. What we have been taught in the physical therapy curriculum that we focus more on the muscles and the bones, and we often neglect all the other surrounding connective tissue. So the take-home message from this slide is whenever you see any patient of the lumbosacral dysfunction, try to evaluate considering all the physiological tissues in place. Now, whenever a patient comes to you with a low back pain, their pain may have a variations. The subjective assessment or the description of the pain would vary from patient to patient and condition to condition. So there could be a stretching pain, there could be a throbbing pain, a dull aching pain. I'll give you clinical reasoning for everything. We'll just first go through the slides. Then there is a constant ache. Then there could be a pain when you move your body part, like do flexion or extension or any of the lumbar joint movements. There could be a fourth type of classification of variation that could be pain on movement, which increases after every repetition or after every movement or after some period of time. And there would be a latent nerve. It's simple. Whenever a patient comes to you, a complaint of a herniated disc, that means the space which has been occupied by abnormally moving the disc out of the vertebral space. Posterior laterally. If the disc has moved posterior laterally, it will compress on the spinal nerves to give a referred pain down to your leg. This typical condition or the scenario is. Similarly, if patient comes to you with any inflammatory reaction to any injuries to your muscles, your ligaments, or your facet joints, they mostly cause a localized pain in that particular vicinity. This particular pain would be more centralized to the lower back. And that's why they have given the umbrella term as centralization. Now, peripheralization is bad. Whenever patient has peripheralization, that means when the nerves are being impinged, your main rule, according to McKinsey, is to get the patient from peripheralization to centralization. So that's a good prognosis. Okay. Now, Hall, scientist, has broke back pain. So whenever you see any kind of back pain, you distinguish them into these 4 categories. 2 of these would be a back pain dominant and 2 of these would be a leg pain dominant. Like patient would come to you with the symptoms which are predominantly seen only in the back, and patient will come to you with the symptoms predominantly seen in the back as well as leg. Okay, so according to the chart system, the pattern, they have classified into a back pain dominant, where specifically the pain is in the back and the buttocks, that is glutes 90% of the time. And this could be because of the minor disc herniation, spondylosis because of the degeneration of the disc, and could be because of the sprain or strain in that particular movement. So this is like a back pain dominant where the pain is in the back as well as glutes. Now this particular pain, if the patient has typically inflection, then these are the causes. And if this particular pain, which is predominantly in the back and happens only on extension, basically it is the facet joint involvement. Now, just to give you one hint, extension, the facet joint gets locked. That's the reason why they cannot perform extra movement and it gives rise to a pain. However, in flexion, the disc has a high chance to come out, just to put it very simple. That's the reason why most of the minor disc issues have predominantly a back pain. Now comes to the leg pain dominant. So you have another 2 patterns here. The leg pain, which is usually below the knee. and happens while you do a flexion movement, it's 100% confirmation that it is a herniated disc impinging on the spinal nerves. If you have any symptoms, if your patient has any symptoms below the knee joint, please make sure that that particular symptoms is because of the herniated disc impinging on the nerve root. This gives you the 100% confirmation that it is a slip disc, like stage 3, the prolapse. Then the leg pain usually below the knee, but is in the extension. Be a pressure on the quada equina syndrome. So keep it simple. Patient coming to you with a back pain in the back as well as glutes. These will be the causes based on their pain aggravations in flexion as well as an extension. Then there could be a leg pain dominant in flexion and extension, could be because of and claudications. Now, which are the major assessment tool and the diagnostic criteria which overall manual therapist and physical therapist approaches? So in other countries, manual therapists are the primary contact person whenever you have any kind of issues going around with the lower back or any spinal issues. Consequently, their diagnostic skills has greatly improved over the period of time. McKenzie has predominantly distinguished the low back pain or the lumbosacral dysfunction into these 3 particular syndromes: the derangement syndrome, the dysfunction syndrome, and postural. Postural is simple, maybe because of any kind of congenital deformities like scoliosis and kyphosis. These 2 are the most important for any physical therapist to understand. The derangement syndrome is basically related to your disc. The dysfunction syndrome is basically related to all other connective tissue except disc. Or you could also keep disc into this as well. Okay, so derangement, typically they are talking about the disc. Dysfunction is related to all the connective tissue surrounding the lumbar joint. Now, when you have a clinical history, that this would be a subjective analysis. You first ask the patient their age. Now, I'll go through this slides a little fast. This usually happens during this particular age group. Okay. Osteoarthritis, where the degeneration starts to take place, and the spondylosis, that is degeneration in the disc, basically at and above 45 years. Malignancy, any kind of cancerous or infections, above 45 years. Strenuous occupations like truck driver, warehouses has more chances of getting a low back pain. Deconditioning syndromes means if you have a chronic pain, there could be surrounding reduced muscular strength. There could be an impaired motor control. Also, there would be a loss of proprioception, so your joint position sense is decreased. So there is a decreased coordination as well as the decreased postural control. Then if you talk about women's changes in the menstruation, irregular menses, and swelling in the abdomen or breast can also sometimes give a referred pain into your lower back. Most of the common causes are the lifting, bending, repeated bending, fall, or twist. Stages of injuries, we have discussed about acute, subacute, chronic. The boundaries on the site of the pain, depending upon the mechanical low back pain, I told you to put it in 2 categories: back pain dominant and dominant, and the posture aggravating pain. The pain gets aggravated while they are sitting or standing or walking or lying or steady posture. All these subjective assessment will give you a correlation towards your main hypothesis, which will generate a clear diagnosis to understand how the posture of the patient is and what abnormal movement does he perform. Pain, if it is a constant pain throughout, why that constant pain happens. It could be because of the chemical hormonal release, because of the constant irritation of the connective tissue. So if patient is coming to you and telling that there is a constant pain throughout the day, clear cut is a chance of having some kind of infection in the lumbosacral joint. That's chemical release is constantly making them aware about the pain. And if the pain is intermittent in nature, then it is short mechanical. In mechanical, it's basically about all your other connective tissues like your bones, skin, fascia, the facet, the cartilage, the degeneration, everything. Constant pain, infection, intermittent pain, mechanical because of all other connective tissue. Remember that. Okay. When you see a posture while in your assessment, on your observation, always keep a holistic approach to all the bony landmarks. Don't just focus on the lower back. There could be a compensatory back pain because of the knee issues or because of the cervical issues. So try to keep the posture assessment majorly focusing on the lower back, but also take into consideration rest all the bony landmarks. Your major focus would be on the spinal curves to see whether all the spinal curve is proper, like if there is any kind of scoliosis or kyphosis, note that. Check your pelvis examination like PSIS and ASIS if they have any kind of pelvic asymmetry. Always check the lower leg, whether it has genivalgum, anti-rotations, or they have a flat feet, and focus more